Adrenal Incidentaloma. When a scan reveals an unexpected adrenal mass, understanding its cancer risk becomes critical. This video breaks down how imaging determines malignancy risk, using specific techniques and measurements through evidence-based content curated by Saboor, fellowship-trained consultant surgeon. An adrenal incidentaloma, a mass discovered on imaging performed for reasons unrelated to adrenal disease, presents a diagnostic challenge that affects up to 4 in 100 adults undergoing abdominal scans. The adrenal glands, sitting atop your kidneys, can harbor various lesions, ranging from benign adenomas to rare but serious cancers. Most incidentalomas, roughly 80 to 85%, are non-functioning benign adenomas that never cause harm. However, between 0.4 and 4% are adrenocortical carcinoma, cancer of the adrenal cortex. 3 to 7% represent metastases from other cancers, and 1 to 5% are pheochromocytoma, tumors producing stress hormones. The fundamental question for you and your physician is simple but crucial. Is this mass benign or malignant? Getting this answer right determines whether you need surgery, surveillance, or no further action. This matters personally because misclassifying a malignant tumor delays potentially life-saving treatment, while unnecessary surgery for benign masses exposes you to avoidable risk. Noncontrast computed tomography measuring Hounsfield units, a scale quantifying tissue density compared to water at 0, represents the most reliable initial tool. Lipid-rich benign adenomas contain microscopic fat that lowers their density. When an adrenal mass measures 10 Hounsfield units or less and appears homogeneous, it is virtually never malignant. In studies involving 3,723 patients without known cancer, every single mass with 10 Hounsfield units or less proved benign, a 100% sensitivity for detecting malignancy when the threshold is exceeded. The images show benign lesion appearance on CT scan. Here is what these numbers mean for you. If your mass measures 10 or below, no further imaging is required regardless of size. The 40 to 58% of benign masses measure above 10, creating the indeterminate category. Masses between 11 and 20 Hounsfield units occupy a gray zone. Research shows that over 90% in this range without cancer history are benign, but some metastases and rare adrenal cancers fall here. Masses exceeding 20 Hounsfield units raise suspicion, though this alone does not confirm malignancy. When non-contrast CT yields indeterminate results, washout computed tomography evaluates how quickly masses release intravenous contrast dye. Benign adenomas absorb contrast rapidly at 60 seconds, but also wash it out quickly. Malignant lesions retain contrast longer. This requires 3 measurements: before contrast injection, immediately after at peak enhancement, and again at 10 or 15 minutes delayed. 2 calculations matter here. Absolute washout uses the formula 100 times the difference between peak and delayed density, divided by the difference between peak and baseline. Relative washout calculates 100 times the difference between peak and delayed divided by peak alone. Traditional cutoffs suggested 60% absolute or 40% relative washout indicated benign disease. But here is where it gets interesting. A recent study of 253 tumors found these thresholds missed 22% of malignancies using absolute washout and 8% using relative washout. Magnetic resonance imaging using chemical shift technique offers radiation-free assessment, particularly valuable during pregnancy or for children. This method exploits how protons in water and fat oscillate at different frequencies within magnetic fields. Lipid-rich adenomas lose signal intensity on out-of-phase images compared to in-phase images, appearing darker. Malignant lesions and pheochromocytomas lacking intracellular lipid maintain their brightness across both sequences. The advantages are clear: no radiation exposure, no iodinated contrast agents that stress kidneys, and superior tissue contrast resolution. Disadvantages include longer scanning time, often 20 to 30 minutes versus 5 for CT, claustrophobia in the enclosed scanner, and incompatibility with certain metal implants like older pacemakers. Studies show chemical shift MRI achieves 89 to 99% sensitivity in patients with cancer history, with specificity ranging 60 to 93% depending on technique. Now you might be wondering whether MRI replaces CORT. The answer depends on context. For true incidentalomas without cancer history, 2 of 3 studies found slightly lower accuracy than non-contrast CORT. Positron emission tomography using fluorodeoxyglucose, a radioactive glucose analog, combined with CT, detects metabolically active tissues. Malignant cells typically consume more glucose than benign ones, lighting up on PET scans. Despite its appeal, FDG-PET CT carries important limitations you should understand. The advantage lies in low false negative risk, meaning malignant tumors rarely go undetected when FDG uptake is absent or less than liver background. Studies show sensitivity between 67 and 100%, with most above 85%. However, the technique is not foolproof. Certain metastases from kidney cancer or low-grade lymphoma may show no FDG uptake, creating dangerous false reassurance. Conversely, benign functional adenomas producing hormones often demonstrate high FDG uptake, appearing falsely malignant. This creates a clinical dilemma. FDG-positive masses require further evaluation even when benign. For indeterminate masses after initial CT, most expert panels judge FDG-PET CT more valuable than MRI or washout CT for ruling out malignancy. But here's something that might surprise you. This test costs significantly more, averaging $2,000 to $3,000 versus $500 for CT, and availability remains limited outside major medical centers. Size intersects with imaging characteristics to stratify risk. The 4 cm threshold appears throughout guidelines, though its significance varies by context. 5 studies, including 4,752 patients, showed 4 cm as a cutoff achieved 77% sensitivity and 90% specificity for malignancy. That means roughly 1 in 4 malignancies measure under 4 cm, while 1 in 10 masses exceeding 4 cm proves benign. Heterogeneous appearance. Uneven density or multiple different regions within one mass significantly elevates concern regardless of size. Combining criteria provides clearest guidance. Masses 4 cm or larger that are heterogeneous or exceed 20 Hounsfield units warrant multidisciplinary discussion, with surgery often recommended. Even in this high-risk category, likelihood of malignancy in true incidentaloma populations can reach 50%, meaning half remain benign despite worrisome features. All images from patients with adrenal masses should undergo review by an experienced radiologist, focusing on both the affected adrenal and the opposite side, which frequently shows hyperplasia or nodules. Evidence suggests multidisciplinary care improves outcomes in adrenal tumor management. The core team should include an endocrinologist, radiologist, and surgeon, all with significant adrenal experience. Multidisciplinary discussion becomes particularly important when imaging suggests anything other than clear benign features, when hormone excess appears, when surgery is considered, or when significant tumor growth occurs during surveillance. Request a copy of your radiology report and identify 3 key measurements: Hounsfield units on non-contrast CT, mass size in centimeters, and whether the radiologist describes the mass as homogeneous or heterogeneous. If your report shows 10 Hounsfield units or less with homogeneous appearance, substantial reassurance exists regardless of size. This combination virtually guarantees benign disease. If numbers fall between 11 and 20 with size under 4 centimeters, recognize you are in the indeterminate zone, where additional testing provides value. Write these numbers down before your physician appointment to facilitate informed discussion. Prepare questions about why specific imaging was chosen and what additional tests might clarify the diagnosis. If your mass exceeds 4 centimeters or 20 Hounsfield units, ask whether your case has been discussed in multidisciplinary conference and what the consensus recommendation is. For masses requiring surveillance, clarify the exact follow-up interval, 6 versus 12 months matters, and whether repeat CT or MRI is planned. If surgery is recommended, ask, what is the likelihood this mass is malignant based on all my imaging features combined? What are the risks if we choose surveillance instead? Will the surgery be performed by a high-volume adrenal surgeon using minimally invasive techniques? If you are worried about someone you love facing these decisions, accompany them to appointments and take notes. The anxiety surrounding possible cancer diagnosis often impairs information retention. Having another person present ensures critical details are captured and questions are asked. Seek urgent assessment if you develop sudden severe abdominal or back pain within a known adrenal mass, which could indicate hemorrhage into the tumor. New onset of severe headaches, palpitations, racing heartbeat, sweating episodes, or sudden blood pressure spikes above 180/120 may signal pheochromocytoma requiring immediate treatment before any surgical intervention. Progressive fatigue, unintended weight loss exceeding 5% of body weight over 3 months, or development of new hormonal symptoms like easy bruising, muscle weakness, or rapid unexplained weight gain warrant prompt evaluation. Imaging assessment stratifies adrenal masses into clear risk categories using objective measurements. Your next step: obtain your complete imaging reports and prepare specific questions about Hounsfield units, size thresholds, and whether multidisciplinary review has occurred. This information is for education. Always discuss your individual situation with your healthcare provider. The European Society of Endocrinology 2023 guidelines on adrenal incidentaloma management provide comprehensive, evidence-based recommendations covering imaging protocols, Hounsfield unit interpretation, and when to pursue additional characterization with washout CT, MRI, or FDG-PET/CORT. Thank you for watching.